So I'll be discussing how CPAP works. So CPAP, or continuous positive airway pressure, is typically used in NIV, or non-invasive ventilation, as a ways to stent the airway open. And it's normally indicated for obstructive sleep apnea, which during obstructive sleep apnea, what happens is while you fall asleep, your airway closes, collapses, and your oxygen saturation drops. And when your oxygen saturation drops, you're in what's called hypoxemia. And hypoxemia is just a special word that means low oxygen in the blood. And this can be very disastrous for many ways, because if your blood's not getting enough oxygen, then it can't work the way it should. And your blood supplies all the parts of your body, everywhere, your hands, your head, and everything. So when there's low oxygen in it, that's not very good. So what CPAP does is it applies a set pressure during inspiration and expiration to keep those alveoli open. So while you're breathing in, those alveoli, which alveoli is where gas exchange happens, it keeps those open so your oxygen saturation doesn't drop. And typically it's normally seen in obstructive sleep apnea. And CPAP, or continuous positive airway pressure, is a spontaneous mode. It can also be seen in post-op patients who aren't completely awake yet, and it's used as a preventative measure just to make sure that they're breathing the right way, and it's kind of weaned off the more that they come awake. So a post-op patient who's sedated a lot, maybe they can't breathe as well on their own, so CPAP is given while they're waking up so that they are oxygenated the way they should be to prevent risks and everything too. So during CPAP, since most of the time it's during NIV, you're going to be wearing a mask or a nasal pillow, a full face mask, oral mask, nasal mask, or one of those special nasal pillows. It can prevent heart disease, diabetes, car accidents. You'll probably see this in the hospital sometimes. Patients who are on CPAP at home who don't wear it, and they come in and they're just completely lethargic, because they're not wearing their CPAP, because they're hypoxemic in the morning and during the day. So they might be sleeping at night, they're not breathing. So during the day, they'll be sleepy, lethargic, their CO2 is high, and they're just not fully alert. I actually saw a patient in the clinical setting the other day who didn't wear their CPAP at night, and we had to give them BiPAP while they're in there, and you can just kind of see them like they're half awake, and then just all of a sudden they wake up and they're like, what's going on? It's because they're not wearing their CPAP at night like they should, and their O2 saturation's dropping in the middle of the night. So during the day, their body's trying to catch up with it and trying to sleep during the day and everything. It's just an ongoing cycle. If you're on CPAP, you should definitely wear it. It's for a good reason. And so I have this written, and there's a big light here, so you might not be able to see everything, but an at-home machine, some patients can qualify for wearing a CPAP machine at night while they're sleeping for sleep apnea or to correct their oxygenation needs. And then, so normally it's seen in NIV, non-invasive ventilation, but you can see it also on a ventilator. So CPAP corrects oxygenation, right? So it's used interchangeably with the terms PEEP or EPAP. So sometimes you might be working on a ventilator with somebody, and your preceptor or your clinician or physician might say, put them on CPAP. Well, it might look different on the ventilator. They might say, well, that might mean give them some more PEEP. Or normally, it's called a Cpap Trial. I have written here, trial for extubation. If they're trying to see if their patient can survive spontaneous breathing off the vent and be able to be extubated, you'll see what's called a Cpap Trial. And what that means is you'll be putting them on a spontaneous mode, normally with pressure support. And what I've seen normally is pressure support 10, PEEP of 5, and they call that a Cpap trial, which means that they're spontaneously breathing and they're trying to see how well they work, if they can be extubated or not. And normally you'll see a Cpap trial, say 3 hours on and then 1 hour off on assisted control. So this is the gist of CPAP. So this is volume control plus. In volume control plus, you set the tidal volume and the I time. And how this mode works is it gives a test breath for compliance, to test the lung compliance. And this is like a dual control mode, so it kind of tries to control both pressure and volume. So what it does is it'll do a test breath with a plateau to vary the pressure to maintain the tidal volume. And during this plateau, you'll see on the waveform on the vent, it'll be very subtle. Like you'll have the waveform and the plateau there very, very subtly, and it changes breath to breath, you'll see on there. So if the given tidal volume is lower or higher than the set tidal volume, the pressure is adjusted to try to maintain that set goal that you have. And another name for volume control plus that I've heard is autoflow. And that's because in regular volume control, you have a set flow. Let's say the flow set on regular volume control is 50. Well, no matter what, that patient is going to get 50 flow. So let's say that patient wants to take more flow. They can't. They can only take 50. So, or they want to take less. So a patient can be air hungry if they want to take in more than 50 flow that's set on a ventilator. And this is more of a patient comfort thing, whereas with autoflow or volume control plus, the flow is adjusted breath to breath. So if a patient wants to take a faster breath, they can go at their own pace. And this is a patient comfort feature of volume control plus that you'll see used with neurological patients, where they have trouble synchronizing with the vent and they kind of want to do their own thing. Whereas if you set a flow, you could get some asynchrony in there. So volume control plus can be useful in that aspect because the patient wants to do their own thing. They want to take maybe they're just not consistent with how fast they want to take their breath. So they want a faster one or a slower one. So with volume control plus, it's not based on the flow, it's based on the I time. You set the I time and that's how you manage it. And what you'll see is you'll kind of incorporate when a patient takes a breath, let's say they're a neurological patient, and you kind of see how fast they're taking it in. You can start with 1 second and almost try to get that synchrony with them, with the vent, and just keep it even and smooth so they're not rejecting it. So they can take a spontaneous breath during the inspiration portion of a mandatory breath in volume control plus because they have an exhalation valve on it. And there's less risks in the pressure adjustment because let's say a patient's lungs are less compliant randomly. It's going to adjust because of that. It's going to adjust pretty quickly because of that, and that can lead to less barotrauma or volutrauma based on the breath that's given. Say you give a patient a certain amount of a set pressure and their lung compliance lowers, and that set pressure that's given on a different mode can damage their lungs. Whereas with this, the pressure varies based on the breath. So if their compliance goes down a little bit or expands just randomly out of nowhere for whatever reason, how the patient's doing or the patient's getting better, say the patient's improving and they have large compliance at first and their compliance is going down, this vent's going to be able to pick that up breath to breath. It's like a dual control mode. So it's going to be able to kind of tell and guess, okay, so their compliance is getting better or lower based on what their needs are. And it's not going to give that big of a pressure the next time it gives that breath. Like it varies pressure. It gives that test breath. It tests the plateau and compliance, and it's working with the patient. Now, this is a fairly newer mode, so I have written on here less clinical data, whereas I spoke about Cpap. Some of the complications with Cpap you'll see is because they're on NIV most of the time and wearing that mask, they'll have skin abrasion or they'll have skin breakdown. And this is a mechanical ventilator mode. With any mechanical ventilator mode, there's risks with ventilator-associated pneumonia, barotrauma, volutrauma, really, but with this mode particularly, there's not as much clinical data because physicians aren't as comfortable using this one because it's fairly new. So you'll see a lot of physicians stick with just regular old volume control or whatever they're comfortable with for that patient. But this seems like a growing mode that's being used more and more. It's also indicated for ARDS, I've seen in the research, and neurological patients to try to get that synchrony. But as for complications known on this, that's specific to this mode, there really isn't as much out there in the clinical research. But I'm sure with the growing use of it in maybe COVID patients or whatever else is coming out there, I'm sure there will be more clinical data. But as of right now, I didn't see too many complications. It seems like a fairly comfortable mode to try to get a patient synchronous with them with the vent. So yeah, that's volume control plus.